Welcome back to the Deep Dive. Today, we are strapping in for a journey that goes right back to the very first few weeks of human life.
Right, to the beginning.
Yeah, and this is one of the most complex, high-stakes topics in medicine, but it's absolutely fundamental to understanding early prenatal care and how those crucial decisions about viability are made. Okay, so let's unpack this. Our mission today is to dive deep into that period before 11 weeks, a time of just astonishing, explosive development. And we want to understand that critical, often life-saving connection between embryology, the science of development, and the precise interpretation of early pregnancy ultrasounds. We're going to reveal the foundational map that clinicians rely on every single day.
That map analogy is perfect. It really is. For anyone working in prenatal care, embryology isn't some, theoretical subject they vaguely recall from school.
Right.
It is the essential framework. It lets them integrate what we know about developmental biology, the precise timing of when things must appear, directly with the imaging technology.
So if you don't know the map,
You can't tell if you're lost. Exactly. This deep dive is essentially a shortcut for you to understand the incredibly precise roadmap they rely on when looking at a scan that, to the untrained eye, just looks like a few small black shapes.
and we're going to break that map down into three major sections. First, we need to understand why this embryologic knowledge is so crucial for diagnostics, for assessing viability. This isn't just nice-to-know info.
Not at all.
This is about determining the health and the future of the pregnancy. Second, we'll tackle the major source of confusion in prenatal care, the two different clocks used to date a pregnancy, and why that distinction matters so much for risk. And finally, we will walk through the precise, systematic, week-by-week roadmap of visible milestones, the actual sequence of organogenesis. Let's start with the immediate payoff. This knowledge isn't academic. It's about life and death, really. How does knowing the embryology map determine viability? It's not just about seeing a structure, is it? It's about seeing the right structure at the right time.
Exactly. The immediate clinical utility is the ability to distinguish normal development from abnormal development. When a clinician looks at an early ultrasound, they aren't just looking for proof of pregnancy.
They're looking for more.
Much more. They're looking for expected structures at specific, very narrow milestones. This means things like the appearance of the gestational sac, then the yolk sac inside it, and critically, the timing of the first signs of cardiac activity.
So if you know the chronological map, you can immediately spot a major deviation.
Immediately.
So if a clinician sees a large gestational sac, but no embryo, they don't just, wait around and hope. The embryology timeline gives them the confidence to make an immediate, definitive diagnosis.
Precisely. If we integrate our dating knowledge, which we'll get to in a bit, with that embryologic timeline, we can identify structures that are just inconsistent with viability. A devastating example is an embryonic gestation.
Often called a blighted ovum.
Right, that's the informal term. This is the definitive absence of a visible embryo when the gestational sac has matured past a certain point. The map tells us exactly when that embryo must be visible. And this framework is also essential for preventing really dangerous misdiagnoses. I mean, think about ectopic pregnancy, where implantation happens outside the uterus.
Okay.
If a patient presents with pain and bleeding, and the gestational age is calculated to be, say, 7 weeks, the embryologic map dictates that we must see specific intrauterine structures by then.
And if they're not there,
Their absence, combined with the patient's symptoms, immediately raises a high-stakes alarm for an ectopic pregnancy, allowing for rapid intervention.
that makes perfect sense. So the map acts as a quality control system for development.
Yeah.
But it's not just about what's missing, right? It also helps identify structural problems early on.
Absolutely. As the process of organogenesis, the actual development of organs progresses, integrating these insights allows for earlier and more accurate identification of structural abnormalities.
Like what, specifically?
This is especially true for the central nervous system. Detailed embryologic correlations allow for earlier detection of things like neural tube defects and other CNS anomalies far, far sooner than traditional second trimester scans used to allow. And even structures like the yolk sac are crucial checkpoints. An abnormal yolk sac morphology, if it's too large or too small or misshapen, that's an early finding associated with a very poor prognosis. So we're looking at size, shape, presence, timing.
It's an entire checklist for viability.
It is.
Okay, that gives us the what to look for. But the second question becomes when to look for it, which brings us to, I think, the biggest potential source of confusion in prenatal dating.
Oh, for sure.
We have to talk about the challenge of dating the pregnancy because two fundamentally different clocks are ticking simultaneously in the clinical setting?
This is a point of frequent miscommunication, between patients and providers. We have two clocks, the clinical standard and then the biological reality. First, there is gestational age, or GA. This is the conventional metric used universally. It starts ticking from the first day of the patient's last menstrual period, the LMP.
Because it's easy to ask, right? It's a date you usually know.
Exactly. It's accessible, easy to calculate, and it's the standard starting point.
And the second clock, embryologic age.
That is the biological reality. It's also known as fertilization age, and it represents the true developmental age of the embryo. It starts at the precise moment of conception.
So the key differentiator is that time lag, which is always about 2 weeks, right? Because conception typically happens about 2 weeks after the LMP.
Exactly. Embryologic age always lags about 2 weeks behind the gestational age you'd calculate from the LMP. So a fetus at 8 weeks gestational age is only 6 weeks old, developmentally speaking. While GA is the standard for paperwork and initial estimates, embryologic age tracked via imaging markers is theoretically far more precise because it aligns with the actual start of development.
Wait, so if LMP is easier and it's the clinical standard, why bother with the atomic clock of embryologic measurement? Doesn't the extra complexity just lead to more confusion?
That's a great question, and the answer is twofold: precision and risk assessment.
Okay.
LMP is often unreliable. You have irregular cycles, unknown dates, or the use of assisted reproductive technologies.
Right. RT changes the whole timeline.
It does. And that's where the embryologic markers come in to refine or correct that initial LMP guess. They act as the internal calibration metrics that standardize the date. We rely on two major markers during the first trimester. Early on, before 6 weeks, we use the mean sac diameter, or MSD. This is kind of the placeholder metric. It gives us a general sense of age when the embryo isn't yet clearly visible, so around 4.5 to 6 weeks.
But the undisputed heavyweight for dating, the measurement that holds the most statistical weight, is the Crown-Rump Length, right?
Absolutely. The fetal Crown-Rump Length, or CRL, is consistently referred to as the absolute atomic clock of pregnancy dating in the first trimester.
The atomic clock. I like that.
Yeah, and studies show these parameters have an incredibly strong statistical correlation, and R value greater than 0.9 with gestational age. The CRL is the most reliable metric because it directly measures the developmental size of the embryo. Once that measurement is taken, the date is locked in.
Okay, now let's connect this dating discrepancy to the so what for the patient, because this feels like the critical part.
Yeah.
What happens if the LMP clock and the ultrasound-based CRL clock don't align?
Well, the danger is the potential misdiagnosis of pregnancy viability. If a clinician is unaware of both frameworks, they might look at an embryo that appears small for the LMP date and mistakenly conclude that the pregnancy is failing,
Oh, wow.
when in reality the LMP dating was simply wrong by a week.
So the precision of the embryologic markers helps prevent unnecessary panic or, even worse, unwarranted intervention.
Exactly. And we have a critical statistic that underscores this need for precision. Studies show that even a small lag, more than 3 days, between the ultrasound-based GA derived from the CRL and the initial LMP-based dating correlates with an increased risk of pregnancy loss.
That 3-day lag is stunning. Why is that difference so significant? It seems so small.
It signals a subtle but really important divergence in growth trajectory. If the body clock, the CRL, is consistently lagging significantly behind the presumed clinical clock, it suggests a developmental lag. It means the embryo is not meeting the milestones required for its supposed age,
And that's a red flag.
a key indicator of underlying pathology or risk. This is why standardizing the dating using the CRL isn't just about accuracy, it's about early risk stratification. The embryology map transforms dating from a guess into a prognostic indicator.
That transition from guess to prognostic indicator perfectly sets the stage for our final section, the chronological roadmap. Now we move from the concept to the actual visual timeline. We're covering that crucial period from 5 weeks to 10 weeks.
Right, which covers the entire embryonic period and all of organogenesis.
Okay, so let's walk through it.
This is where the map becomes tangible. We are tracking the systemized timeline week by week, ensuring everything is proceeding as it should. We start right around 5 plus 0 to 5 plus 6 gestational weeks. Embryologically, the gestational sac forms, the amniotic cavity is just initiating. On ultrasound, this is still a very rudimentary stage.
So what do you see?
You see a clear, round, or oval black space in the uterus. That's the gestational sac. But crucially, the embryo itself is rarely visible, and cardiac activity is absolutely not expected. If someone sees a gestational sac this size and expects a heartbeat, their dating is definitely wrong.
Okay, then we hit the major turning point around 6 plus 0 to 6 plus 6 weeks. This seems like a transition from placeholder to life.
It truly is the biological ignition point. The embryo elongates from a microscopic clump into what clinicians call the fetal pole, the heart tube forms, and for the first time it starts beating. Limb buds also begin to appear. On the scan, we see the distinct yolk sac. The small fetal pole becomes visible, and early cardiac activity may be detected via transvaginal ultrasound. When we see it, the heart rate is typically around 90 to 110 beats per minute.
And that detection is a major viability confirmation.
Huge.
So moving into 7 plus 0 to 7 plus 6 weeks, the picture starts to become much clearer for the technician, right?
Yes. Organogenesis is now beginning in earnest. The limb buds are lengthening. The embryo is larger with clear, measurable cardiac pulsation. This is the sweet spot where the crown-rump length can be measured accurately and reliably, confirming or correcting the gestational age.
Locking in that atomic clock.
Locking it in.
And by 8 plus 0 to 8 plus 6 weeks, what kind of detail are we seeing now?
The major organs are really starting to take shape. Early facial features are forming, and limb differentiation is occurring. Sonographically, you see a much more curved body shape, the classic C shape. Limb differentiation is clearer, and we can begin visualizing the developing regions of the brain. The amnion surrounding the embryo becomes clearly defined inside the larger chorionic sac.
That sounds like incredibly rapid specialization.
It is. The 3D printer is working overtime. Then look at 9 plus 0 to 9 plus 6 weeks. This is often when the patient may feel they are moving into the safer zone. Ongoing organogenesis continues. You get the external ear and eye pigment appearing. And for the first time, we often see spontaneous embryonic movements.
Not movements the mother can feel, obviously.
No, not yet, but visible twitches and shifts on the screen.
That must be incredibly reassuring to see. And how has the cardiac rate adapted to all this growth?
The anatomy is increasingly complex with visible limb and digit formation. You can really start seeing the tiny fingers and toes, not just buds. And that cardiac rate is robust and much faster, accelerating to typically range from 140 to 170 beats per minute.
From 110 to 170 in just a few weeks.
Yes, that acceleration is a key marker of developmental progress and health.
And finally, rounding out the embryonic period at 10 plus 0 weeks. We are shifting into what is considered the fetal period.
10 weeks marks the formal completion of the embryonic period. All major organ systems are now present, though still immature. Embryologically, the intestines complete their final movement back into the abdomen, and the fingers and toes are distinct.
So it looks like a tiny human.
It does. The fetal shape is well formed, the CRL is now highly accurate, and the cardiac activity is consistent and stable. This systematic week-by-week tracking ensures practitioners can determine if development is proceeding normally and supports that precise, timely interpretation of that initial, crucial ultrasound.
That roadmap provides such systematic clarity. To quickly recap, we've established that embryology is vital for enhancing diagnostic accuracy and assessing viability. It's essential for correcting dating errors between that estimated LMP clock and the precise CRL atomic clock.
Right.
And it provides the definitive week-by-week roadmap for the crucial first 11 weeks of development.
I think the key takeaway here is just the power of precision. That ability to distinguish between the abstract gestational age calculation and the actual developmental precision provided by embryologic markers like the CRL, that's what separates standard clinical dating from truly insightful prenatal diagnostics.
It moves the conversation from estimation to measurement.
Perfectly said.
So, we've established the critical nature of these benchmarks and that 3-day risk factor. But if this science is so precise and so vital to risk assessment, what keeps this knowledge from being perfectly applied every single time?
That is the ultimate question, and it brings up a real complexity in the field. Given the clinical significance of dating discrepancies and the theoretical precision of embryologic age, this raises an important question.
Which is?
How does the acknowledged lack of consensus on standardized reference charts and cutoff values for these embryologic markers, the exact measurements for normal, how does that impact the consistent application of this precise science in routine practice?
So different clinics might use slightly different numbers.
Exactly. If every clinic uses a slightly different cutoff for viability or for dating, it can potentially lead to varied advice or even intervention delays across different systems. Precision is essential, but standardization is the key to ensuring that precision benefits every patient consistently. That need for universal consensus is a complexity worth exploring further.